Okay, so thank you for allowing me to be here, and you guys are almost through to your break. So I also talk really fast, and huge topic, very close to my heart. If you have other questions afterwards, hopefully we'll have time for it, and then you can always come and find me. So we're going to go over breast cancer surgery and then subsequent care. So I have no financial disclosures. To start our overview, so what are the most common breast cancer surgical procedures, indications, expectations? Then we'll go into immediate breast surgical care concerns, and then of course long-term breast surgical care concerns. And you're gonna hear a lot of the same themes, some of which we just heard, and a lot of stuff. Hopefully that's a review. So I think in general, our goal with cancer surgery, in particular with breast cancer surgery, is just to do more, to do less, right? Our goal should be to put me out of a job, right? So we need to identify people early. We need to educate them, meaning that you can get same results with less surgery. And then, of course, finding the people that are at highest risk and what can we do to decrease those risks. So my focus of this huge topic is just going to be on the breast surgeries, the subsequent care, and then I'll put the disclaimer here that my focus is on cisgender women because that's the majority of what we treat, but of course all individuals can get breast cancer. Some of the information is translatable, but not all of it. So global overview, right, treatment for breast cancer, you guys know this, surgery, medications, radiation, and the first step for everybody is what do we start with? So for early stage breast cancer, that's going to be surgery, and that's because a lot of surgery is diagnosis. It just tells us how big is it, has it gotten to the lymph nodes yet, and then we take that information and people smarter than me say, okay, what's the best way to prevent it from coming back? So those adjuvant therapy recommendations, medication and radiation are based on the surgical pathology. It's important that many patients don't understand that you need more than just surgery to treat cancer. This is always something I have to emphasize. So neoadjuvant therapy, obviously this is amazing and can do absolutely incredible things and allow me to de-escalate the amount of surgery that I have to do. This is based on tumor characteristics, and then we can use this to facilitate patient care goals, do less surgery, and then de-escalate treatment, such as axillary dissections, which of course are highly morbid. I will say in the world of breast surgery, even if it looks like we're having a good response on exam and imaging, we are still recommending surgery, but I'm hopeful that we'll get better with our imaging, we'll get better with our sampling, and of course we can decrease that to some degree. So the most important consideration, or the most important thing you have to let people know with breast cancer treatment with respect to surgery is that there is equivalent survival of breast conservation therapy, lumpectomy, versus mastectomy. And so most people are going to have the choice. Now, some people may actually choose to do bigger surgery, and that's fine if that works for them. But again, you have to offer breast conservation therapy. So I can't walk in and say, nice to meet you, both sides mastectomy. But they can say to me, nice to meet you, both sides mastectomy. Of course, I still have to offer the alternative, right? But this is individualized, right? So we individualize this to the clinical scenario, right? You take into account where the cancer is located, the age of the patient, what's their medical comorbidities, what's the risk of recurrence, do we have to use radiation, can we get out of radiation, family history, genetics, of course the patient's preference matters, right? And a lot goes into this. We all look at the world differently, we have different values, and people feel very different about their breasts. There are socioeconomic barriers that unfortunately we have to take into account. Some insurance is very difficult to get reconstruction, so we try to fit the treatment to the patient as much as the cancer allows. There are a few contraindications to lumpectomy, but these are dwindling. And then in general, it's always important to emphasize to patients with breast cancer surgery that regardless of the surgery you choose, if you have an invasive cancer, you're gonna need some medications, because a lot of people falsely think, I'm gonna do a both sides mastectomy, I get out of chemo. That's not true, right? Because the decision for chemo is based on the tumor characteristics, the risk of distant recurrence, right? And surgery is a local treatment. And surgery is simple, right? We just need to get a negative margin and reasonable cosmetics. And of course, cosmetic perspectives vary. So a lot of information on here. Lumpectomy is where, and you guys know this, where you just remove the tumor itself. You need a margin. We don't need a big margin, but we need some, and you keep the remainder of the breast. Lumpectomy comes generally with adjuvant radiation. Now, how much is going to vary depending upon the cancer itself, margins, lymph nodes, age of the patient. I always say if you're going to do a lumpectomy, you have to be open to some radiation, and then you have to be open to surveillance, because if anything comes back, we need to find it and treat it and have that patient do okay. So this is a deal breaker for a lot of patients because they don't want to do the imaging, they don't want another biopsy. The idea coming in for a mammogram can trigger emotional response. So that would be someone that maybe you would steer towards a different direction. Most of our lumpectomies are guided by imaging these days. We're better at finding things early. And so the radiologist finds the finding, they biopsy, they put a little marker in there. Then I use that imaging, and radiology will set me up for surgery. There's a variety of different ways we can do this. Traditionally, we used wires. We don't really do those much anymore. There's a whole bunch of different localization systems. And what that is radiology can tell me where I go. I have a little detector to kind of put on there, get down to the area, make my lumpectomy, take that chunk out, take a picture of it with an x-ray that I have in the operating room with me, and then I should be able to see my biopsy clip, the image abnormality, and then I can tinker and take a little bit more tissue if I need to based on that imaging, based on my experience, based on what it looks like. But this is still a crude surgery for a microscopic disease, right? And so the patients don't always have real-time data. You have to wait 7 to 10 business days to figure out how you did, and then there is that risk. We're pretty good at this still, so I only say about 10% of the time, but sometimes you do have to come back for another lumpectomy. But lumpectomy overall, it should be offered because it is just less, right? So it is a day surgery. A lumpectomy by itself, if you don't have to do axillary staging, you can do with local and monitored anesthesia care, so essentially just sedation. You're back to work quickly. It's about 2 weeks that I put people on restriction, and then they can go back to the rest of their lives. And then it's less pain, and then in general, there's less body image changes, less sexual changes, but of course, even lumpectomy patients can have some of those things. Mastectomy, of course, is just a bigger surgery. This is where we're removing of the entire breast down to the chest wall muscle, so we don't remove the muscle. But no mastectomy is perfect. We can never remove all the breast tissue, and so patients have to understand that there's still a local recurrence risk. Cancer can still come back here, even after I've done a mastectomy, and of course, as I keep reiterating, cancer, especially an invasive cancer, is a full body disease, right? So you can do this massive big surgery and it can still come back elsewhere. And then patients, sometimes we can get out of radiation with mastectomy, but sometimes we still need it. The decision for unilateral versus bilateral is pretty much a shared decision. We should not be routinely performing bilateral mastectomies, but in some instances, it is reasonable, such as in certain genetics, because those patients are more likely to build a second cancer in their lifetime. So either in the same breast or the other side, so probably reasonable to do the bigger surgery. But for most people, this is a decision made because of psychological causes. They want to avoid imaging. They want balance. They can't sleep at night because I don't want my breast on my body. The simplest mastectomy that we do is where we're removing as much as possible, and even that still has a risk of local recurrence. So, and as you go through the rest of the mastectomies that we do, skin sparing or skin and nipple sparing, there's a little bit of breast tissue, a little more breast tissue that's left in all of those, but they're all still considered appropriate. So I offer patients all the different options. A simple mastectomy is the easiest of the mastectomies to heal from. Generally, when we're doing this, we're trying to achieve what's called an aesthetically flat closure, where we're trying to make nice, neat, even incisions. And the patients that want this, they really want this, and they love this. I have triathletes, I have people that it's really important to them to have this, so we have to remember that we need to offer this. And a simple mastectomy, people heal from pretty well. It's not that painful, and they're back to most of the things they want to do within 4 to 6 weeks. The other mastectomies that we do, skin sparing and skin and nipple sparing, these are mastectomies we do with plastic surgery reconstruction. And so this is just more. So plastic surgery reconstruction is a reconstruction. We are rebuilding. And so this is usually more than one surgery. Oftentimes in the cancer center, we're doing this as a staged approach. So first we do the mastectomy. We save either the skin and remove the nipple areolar complex. That's usually, I say, because of angles and gravity. If the nipple's not in the right spot, we can build a beautiful breast, but it's going to be at your waist, right? So we bring them up to where we want them so you get the nice perky Barbie boob, okay? And then sometimes we can save actually all of the canvas, the skin, and the nipple, which psychologically is wonderful when we can do it. But the first surgery, we save that canvas on the front, and then plastic surgery puts in a placeholder, a tissue expander, a little plastic bag that we pump up with air or fluid. They heal around that, and then they need a second procedure, either to use their own tissue, autologous reconstruction, or implant. So it's just more for these patients. It's more healing, more risk for infection, and then it can delay to adjuvant therapy. So we do have to be careful that sometimes we get caught up in the cosmetics, in what the patient wants, and we're hurting the cancer treatment. So there are times we just have to be careful with that. For all of these patients, mastectomy is an amputation, right? You are losing a part of your body that is mapped in your brain, right? So there's phantom pains, and then patients go through grief. And so for the right patient, mastectomy is lovely, because some people, we are all very different humans. Some people it doesn't affect them as much, but for most people, especially patients who didn't choose it, this is a lot. They have pain, they have phantom symptoms, and then it can really change people's body image, and then sexuality, things you don't like to talk about, but it's true. Okay, axillary staging, we mainly need this for adjuvant therapy recommendations. So we used to think we needed to remove healthy lymph nodes. We don't need to do that. We just need to make sure, did the cancer get there, and then use that information to guide our other treatments. So ideally, we try to minimize the extent of dissection because, as you all know, and we keep hearing, lymphedema, right? We try to, or we can, use radiation interchangeably with surgery, and we do think that this decreases morbidity, meaning that you can use radiation to allow me to do less surgery. So sentinel lymph node biopsy, this is where we're mapping out the lymphatic drainage of the breast, the axilla. We remove the first couple lymph nodes that the breast will drain to, because those are the most likely to have cancer in them. If they're negative, we don't have to take anything else, but if they're positive, then depending upon how so, a lot of nuances here, sometimes we have to do more. But in general, sentinel lymph node biopsy is where we try to start with most patients. And then if we can't start with it, we try to treat them with neoadjuvant and to get them into that situation. This is what we call a targeted approach to the lymph nodes to try to make sure that we're doing less surgery when we're able to do so. But it is important to understand, even with sentinel lymph node biopsy, there's still a risk for lymphedema. And these are lifelong risks. So all patients, we have to debate the advantages of, do we use axillary staging, do we not? And we are backing away that choose wisely campaign in certain instances to not even do this in certain patients, because if it's not going to change what we do, why are we doing it, right? Axillary lymph node dissection, I still do this occasionally, but in some ways this is now just reserved to clinically palpable disease. We didn't do neoadjuvant, right, or residual disease after chemo, and even that, especially that second one, we're trying to back off and say, do we really need to do that? Okay, so immediate post-op surgical issues, seroma is a big one. Everybody gets this. So lumpectomies get seromas, mastectomies get seromas, and that's just your natural response to healing that raw surface. And that's why we use drains. So drains in mastectomy patients are in for 2 weeks, so that's probably the biggest thing people complain about. Again, mastectomies and amputation, you lose the sensation, you lose that sexual function, you lose kind of everything in that area, but they can feel their drain. So they're gonna say, I hurt right here. It's like, well, yeah, that's not numb. We try to decrease the immediate post-operative care, post-operative pain with nerve blocks. So we really should be pre-treating pain, doing nerve blocks before we even do the surgeries. And then This was mentioned before, they're all tired. Even lumpectomy patients are tired. They try to go back to work after 2 weeks, but they're exhausted. And that's just part of surgical healing. And then I think the other important thing to mention here, which was already thankfully said, is we need to prehab, right? We need to set our patients up for success. And oftentimes we know surgery is coming for a long time. We treat them with neoadjuvant therapy. And so we really need to educate that patient, educate the caregiver, and then focus on making them as strong as possible as they come into surgery. So every time I see somebody, are you eating? Are you getting protein? Are you exercising? People do better if they're moving during cancer treatment. And obviously, we know in the surgical world, if you come in with low muscle, you're not going to heal, right? So we need to set our patients up for success, right? So finally, as we get out of that acute post-op phase, which generally that's what I'm managing, this is where a lot of what you guys do come in, is how do we transition that patient as you're exiting acute treatments into survivorship, into surveillance, and how do we treat all the things we've done to patients. So again, the less surgery we do, hopefully we can have less of these things, but they're still gonna happen. So pain, scar, and lymphedema are the big ones with breast cancer treatment. Lymphedema, again, this is a lifelong risk, so it doesn't go away, right? So what is most important is you just educate patients, and then this is on a spectrum. You can have patients who are like, gosh, I didn't do that much to them, why do they have so much? You can have, man, we did massive surgery, radiation, and you're just fine, right? So it's sometimes hard to predict. Comorbidities matter with this too, but you have to educate patients that it is forever, and then give them tools to manage that symptom. This can be massage, focused physical therapy, acupuncture. There are, in more severe cases, where people use compression garments, as well as, I think these are pretty cool in the right individual, lymphedema pumps, particularly older patients who can't do their own massage, because you're like, massage it. They're like, I can't do that. So this does it for them. Psychological symptoms, coming back to these in breast cancer patients, is everybody, right? So everybody, lumpectomy or mastectomy patients, are gonna have some sort of psychological symptoms, and in reality, that's any cancer, right? They go through grief, it may be a situational depression, anxiety, and then the body image changes and the sexual changes are everybody. Now, how you fix this is, of course, individualized, but I don't think we're really there yet, but I think what is important for patients is just to recognize it exists, right? You have to ask. And then you gotta normalize it. You gotta say, yeah, everybody feels that way. It's gonna change their sex life. It's gonna change how you look in the mirror. And then remember that a lot of these patients are going through those body image changes, that amputation. So what's the best way to fix that? Retrain your brain, right? Look in the mirror, touch, feel, like just train your brain. This is now me. If you never look at it, your brain's not gonna figure out that's you, right? And then socioeconomic changes, I think particularly in young breast cancer patients, this is just devastating what cancer does to these people. You're at the beginning of your career, your life, and then you're bankrupt, right? You can't pay for it, you can't work, you can't educate yourself to get to a new career. So we really have to do better about supporting people as they're in this process. And I think, the socioeconomic impact of cancer is just underappreciated. And then as my last couple seconds here, I think it is really important that we try to foster this sense of a new normal, right? We're not gonna get people back to kind of where they were, where they were before, right? But we can get them to where they're going. And so there's a lot that can happen with people in cancer treatment that is life-changing, right? I've seen people start businesses, I've seen people go into advocacy, I've seen people, just go back to their regular lives, but it's kind of finding that fit to get people where they need to be. So that's all I got. I don't know if you have any questions for me.